Today's our guest is Partha Chakraborty. He's MD Homeopathic, BHMS, BSc, FSS, and FF from Lincoln University College. And I am welcoming Bob Lim from Malaysia to moderate this program.
Good day, everyone. Greetings from Malaysia. In our language, we call it Salam Bahagia, Salam Sejahtera, and good day, Guten Tag, Hola, Namaste, Namaskar. We are very thankful for IFPH for inviting us to organize another webinar from Malaysia, and our distinguished guest today is Dr. Partha Chakraborty. He's a professor, and we are treating him as a Malaysian right now because he represented Malaysia, and he is an associated professor in the Lincoln University College, Malaysia, which has organized the second university to give and organize a BHMS course, Bachelor of Homeopathic Medical Science. In Malaysia, we have only 2 universities offering this course. Okay. Dr. Partha has been very familiar with Malaysia, and she has been many years have come to Malaysia and have associated with PPHM, which is the most active homeopathy medical association in Malaysia. So he has come to share his knowledge in his early years. And according to Dr. Partha, his resume is very, very long, seeing 200,000 cases in clinic over the practicing years. If I would tell his story, I think I will cover most of his time. So he has been a visiting homeopath in the clinic Zara, Kuala Lumpur also. As I said, he is the assistant professor of the Lincoln University College in Malaysia, and he was also the former assistant professor of the BB Homeopathic Medical College in India. So he's visiting faculty and says to PPHM. PPHM means in our Bahasa Malaysia language, our Malay language, it means Persatuan Perubatan Homeopathy Malaysia, which translated into English means the Homeopathic Medical Association of Malaysia. Okay, that is one of the earliest, if not the earliest association that is founded in Malaysia. We have a few associations. Now it's under the umbrella of the Malaysian Homeopathic Medical Council. So Dr. Partha has many years of experience, and he has treated over 2,000 cases, as I said just now. And one of the highlights that he has written a lot of medical papers, and clinical research papers, like the patient care, medical data, interpreting medical advice to training staff, students, and doctors. And he has the area of expertise is teaching the subject of homeopathy to students and doctors. And he has experience in history, undertaking routine diagnostic investigation and daily walks around. So he has a very, very years of experience to share with us, practical and also lecturing. So he has provided expert physical check, diagnosis, advising patient and everything. And he has written many books. That is very important. He has written many books and authored by a senior author under Mrs. Anjali Chakraborty. That is the paper on sex hormonal disturbances. Then he has connected with the paper of the case of Bell palsy, and the paper on thyroid disorder and his homeopathic approach, and the paper in homeopathy in the light of scientific observation, published in the Ringer's Homeopathic Medical Journal, Volume 3, Number 1, January to March 1993. And he also written a paper on the attention of deficit hyperactivity disorder. And he did that with managing with cancer repertory. And it was published in Berita Homeopathy, that is the Malaysian Homeopathy Association journal. at that time. He was quite active. And he has written on post-traumatic stress disorder by phosphorus, and also the appropriate use of a nozzle called carcinosin. An interesting case is on a trigger finger, case on tennis elbow, and a case of appendicitis. Appendicitis is a gastric infection and a pediatric case. And he has written a case on acute low back pain and common walks on fingers and contact dermatitis on toes. Then also a case on impetigo. That is also a pediatric case. So he has also participated and got involvement as a team member of the malaria control team at Subdivisional Hospital in Tripura, which is sponsored by the National Institute of Homeopathy, Government of India. And NIH is a very famous government homeopathy college in India. He holds credit of expanding sales and business of homeopathic medical books nationally and internationally. And he's a fellowship of the Faculty of Homeopathy Malaysia International Award in 2022. And he is a life member of the Homeopathic Medical Association of India. And throughout his career, he has attended 3 international conferences on homeopathy in 1998, 2000, and 2008 in Malaysia. And I was there when he was sharing his lecture. And he is also visiting the faculty of the Homeopathic Medical Association of Malaysia in 2092 and 2012 and 2016. And he is also visiting Malaysia quite often as a visiting homeopathic physician in clinics in Selangor, Penang, and Malacca, Malaysia, from August 2013 until 2019. So today we have a very interesting subject, and that is he's going to share with us the management of brain tumor with homeopathy and with case presentation. And over to you, Professor Dr. Partha Chakraborty. Thank you very much.
Yeah. Good evening, Bob. One of my best friends that I'm having in Malaysia. And welcome all the members over here. And I thank the members of the International Forum for promoting homeopathy for providing such an platform for all of us to deliver something that we have experienced in our life. I've actually passed from National Institute of Homeopathy. I'm the first batch graduate from National Institute of Homeopathy and a PG from Muzaffarpur University under the government, under the private college in Patna. And then I've been practicing over here in India and also in Malaysia. And as Bob told that I have been going there in the university. So I have, as it is common with everybody, I have seen in my practice a lot of cases of which there is a subject neurology which is too much interesting for me. And neurology, we only know 10% of neurology so far. There's a opinion of a very big neurologist that we only know 10% of the neurology. Okay, and of that, brain tumors form a very little portion. I have taken this subject because this subject, the name brain tumor, elicits a panic reaction among the patients, elicits a panic reaction among the doctors, and more so among the homeopaths, because nowadays, in the days of the super specialty hospital, the super specialty hospitals are abounding everywhere in India, in every nook and corner of India. And people, they are raising doubt whether as homeopath we can provide some relief in these cases. And I'm fortunate to see many cases of brain tumors, and I've been able to, cure some of them also, relieve some of them. So that is the reason that I've taken up this subject. It's a very difficult subject, I know. It's a very challenging subject. And I think that if I can share my experience with everybody over here, and over here, there are many experienced physicians, I am sure. They have also seen their brain tumor cases in their clinical practice or in their hospital duty. So I'll be very happy if you just listen patiently to my sharing. So I've divided my lecture into 3 portions. First, there will be a small introduction about brain tumors because some of the students are there over here. So I'll just tell something, very little information of the brain tumors, what are brain tumors, the types of brain tumors. And then I'll be sharing the management principles with homeopathy. Especially, I'll be sharing my own observations that I've been seeing with the patients in clinical practice. And finally, I'll be sharing 3 cases. I'll be sharing 3 cases from my own practice, out of which one case I have selected that is a very acute case. It was an acute exacerbation in a brain tumor case. I have selected this case specifically with some video because I want to instill the confidence that we can do very good work in brain tumor cases, especially when the patient is passing through an acute phase. We can help these patients with our homeopathic medicines without asking them to go for some allopathic medical help. That is the reason I have taken up one case with video illustrations, and there will be another 2 cases with case reports, of course. So, with all your permission, I'm just starting my seminar. So, before I go into the details, the normal physiology that we know, the normal physiology of our body is that normal cells, they die and new cells take their places. That is the basic physiology in our system, in our body, that is going on. It's the same in the brain also. In the brain also, there's a difference in the brain, of course, with the other tissues. In other tissues, the cells die, and in our normal tissues, we know that old cells die and new cells take their places. But in brain, the brain or the nervous cells, we have to remember one thing in neurological cells, that the neurological cells, once they die, there is no question of regeneration. Okay, so in brain, what happens, sometimes some extra, mass develops in the brain, which results in brain tumor. So what is a brain tumor, or rather, it's better to call intracranial space occupying lesion. Brain tumor can be called intracranial space occupying lesion. Anything which is occupying a space inside the brain, resulting in some symptoms out of pressure or out of anything, that can be attributed as a brain tumor or SOL. So the definition goes like this: mass of tissue formed by accumulation of abnormal cells. Mass of tissue formed by accumulation of abnormal cells. Now, these cells, though unwanted, grow and cause problem. And this is the problem with which the patient comes to us. This is the problem with which the patient comes to us. Over here, you can see a picture. There's a brain and there's a tumor. I've just illustrated it. Now, types of brain tumor. There are mainly 2 types. So we can classify brain tumors into 2 types. The first is benign or malignant. This does not require any explanation because many of the tumors, they are benign. They don't have any characteristic cancerous affections, so they are called benign tumors. And those who are cancerous, they are called malignant. So this is a very broad classification. And another classification is primary or secondary brain tumors. Primary brain tumors means the tumors which are originating in the brain tissue or brain cells, nerve cells. And secondary or metastatic brain tumors denotes those tumors who results from metastasis from other organs. More commonly, the lungs and the breast. The tissues from the lungs and breast cancer, they travel through the blood and reach the brain and form some cancerous growth. That is called metastatic brain tumor. So primary, which is originating from the brain itself; metastatic or secondary, that means which is originating from a other organ and settling in the brain. This is the broad classification of brain tumor. Now, primary tumors, or the tumors which are arising from the brain itself, they can be classified into 4 portions. First is the gliomas. That is the commonest type of primary brain tumors that we are having. Why gliomas? Because they are originating from the glial cells or the brain cells. The brain soft cells, they are known as the glial cells. The second type is the meningiomas. I will show the illustration in the next slide. Meningiomas. Meningiomas, they are the second commonest primary tumors that is found in the brain, affecting mankind. The meningiomas, they originate in the meninges. We are having three meninges: dura mater, arachnoid mater, and pia mater. And if any tumor arises from the meninges, they are known as the meningiomas. They are mostly benign. Another group of very common primary tumors is pituitary adenomas. That means these tumors, they originate in the pituitary, that is remaining in the almost in the base of the brain. And the fourth one is the nerve sheath tumors, that is called the myelin sheath, the sheath that is covering the nerve cells. From there also some tumors can arise. These are the four basic type of primary tumors. I've just given one illustration just so that you can just understand. This is the cross section of an MRI. This is a brain tumor. Mostly this is a glioma. This is originating from the glial cells. And this is the most prevalent type. 78% of them are malignant. This primary tumor, 78% of them are malignant. So gliomas are you have to treat them very cautiously. Second type of primary brain tumor, I told they are meningiomas. So in this illustration, you can see this is the bony portion, and this is a meninges, and from the meninges one SOL has come up. This is the normal cerebrum, and this SOL has come up from the meninges, so this is known as a meningioma. This is another picture also over here. This is another type of primary brain tumor. There is a third type of primary brain tumor that we are having. There is a view from the below portion. There is a pituitary gland. So pituitary adenoma, that is also another type of primary brain tumor. Over here you can see it. There is a pituitary, the sella turcica. And the fourth one can arise from this myelin sheath. Okay. They are the primary brain tumors. Now, I've listed some of the benign tumors because whenever a patient comes to us in our clinical practice, we have seen that most of the brain tumor patients are coming from the allopathic doctors. So they are bringing the papers with us, and if we are accustomed to these terms, then it will be easy for us to have a fair idea. So these are the different types of brain tumors. Chondromas, these are the benign tumors. Chondromas, craniopharyngiomas, very common. Gangliocytomas, meningiomas, we have already told. Pineocytomas, not very common, with rare tumor. Pituitary adenoma, very common primary brain tumor. And schwannomas. Schwannomas also, they are quite common. Acoustic schwannoma or anything like that. That is arising from the Schwann cell in the nerve cell. These are the benign tumors that we are commonly seeing in our clinical practice. And some of the malignant tumors that we are seeing in our clinical practice, they are astrocytomas. Today I'll present a case of astrocytoma before you. Astrocytomas. Why this is known as astrocytoma? Because these are originating from the brain cells which are star-shaped, looking just like a star. So they are known as astrocytomas, quite common. Ependymomas, and then glioblastoma multiforme, very common and malignant, very hugely malignant brain tumor, medulloblastoma, and oligodendroglioma, of which astrocytomas are commonly coming to us in our practice. Now, symptoms, why do the symptoms occur? Because it is in the brain. It is in the brain. We cannot see it. Now, why do the symptoms occur out of the brain tumors? This is occurring because of the increase in the intracranial pressure. Because we know in the brain, there are some ventricles. There are two lateral ventricles, there's a third ventricle, there's a fourth ventricle, and all the ventricles are actually connected with the CSF, cerebrospinal fluid. And whenever there is a tumor arising in the brain, it causes intracranial pressure to build up, or it obstructs the fluid from moving from one ventricle to another, resulting in intracranial pressure. And this increase in intracranial pressure will result in some symptoms which will be presented before us in the clinic. And sometimes this focal cause, that means due to the positional effect, it can affect some of the symptoms. Very recently, I am seeing a case of pituitary macroadenoma. Pituitary macroadenoma, the tumor is located in the pituitary gland, and it is very near to the optic chiasma. You know, there is an optic chiasma in the brain, and it is located very near to the optic chiasma, having a pressure effect on the optic chiasma, resulting in the blurring or near blindness in the left eye. Now, after treatment, that is gradually, recovering, and the patient is having a very good vision of the left eye now. So this is called focal cause. That means focal position of the tumor can cause some symptoms. A common clinical manifestation in brain tumor that we see in our clinics, the very common symptom is a headache. This is the commonest presentation of brain tumor in our clinic. Whenever a headache patient comes to us, we must not neglect. We must have in our back of mind that this can be a very serious case. And the typical headache of brain tumor is a constant pain or ache. It may be much more, it may be very low-grade pain, but it's a constant ache, and that pain is aggravated on awakening in the morning. And the pain is felt on sneezing and coughing. This is the commonest presentation of brain tumors. Other clinical presentation, this we are seeing in our clinical practice. The other presentation is nausea. The patient can come with sudden nausea. The patient has started suddenly vomiting, nausea and suddenly vomiting, and that vomit is uncontrollable. It is going on for several episodes of vomiting has been going on since morning. So this sort of severe vomiting, serious cases of vomiting might invoke a thinking in you that this may be a case of intracranial SOL. And mostly this vomiting is present where the cerebellum is affected, the posterior portion of the brain is affected. And drowsiness is also a common presenting symptom, but this is present in the later stages. Drowsiness, always the patient feels very drowsy, lethargy. Diplopia, when the tumor is quite big. I was just telling you that I'm seeing a case of pituitary macroadenoma. So if by chance the position of the brain tumor results in pressure effect upon the optic nerve, it can result in diplopia. Even it can result in blurred vision. The patient will see something blurred vision, or even sometimes the patient will see double vision. And the patient might present with disturbances in speaking, understanding, and writing even. While writing a check, while writing in a copy, he will write something different. So these changes in the normal lifestyle will warrant a thinking that this patient might suffer from an intracranial brain tumor. And this is another presentation I have seen in my clinical practice, and today I will be presenting a case on this, ataxia. That is not exactly a paralytic condition, but it's an incoordination. It's an incoordination having a disturbance in movement. And this is commonly seen in cases of advanced, or big intracranial SOL, space occupying lesion. The patient will be moving in a drunken gait, as if he has drunk alcohol. His gait will be like that. There will be difficulty in walking, difficulty in skill movement. There will be no hand-eye coordination. Cannot do anything with the hand-eye. This coordination will be affected in these patients. And this is one of the most common presentation in our clinical practice that we see, that suddenly a patient comes to you with a history of seizure. Suddenly she has fallen down in the school while praying. She has fallen down while she has gone to the market. He has gone to the market and suddenly has fallen down in the market. And after brain scan, it is found that he is having a big brain tumor inside. Before that, he had no manifestation, no symptoms. This can be also like that. So seizure can be a presenting symptom. Seizure can be generalized, or seizure can be single twitching of muscle. Single twitching of muscle. Just the eyelid will be twitching. Just the facial muscles will be twitching. This sort of single muscle twitching is also a presentation of brain tumor. And if the patient complains of sudden loss of smell or sudden loss of taste, anosmia, or sudden loss of taste, as we have been seeing in COVID, this is also one of the presenting symptoms of brain tumor. And these are some rare presentations. Abnormal respiration, normal respiration rate is 18 to 22. If the patient has has got more than 22 respiratory rate, you can think of doing a scan of the brain also. Systemic hypertension, unconsciousness, and comatose patients can also come to you with brain tumor. Now, there are some facts regarding intracranial tumors. It affects 11 to 19 persons per 1 lakh people and accounts for 85 to 90% of the primary CNS tumors. Brain tumors are most common cancer in group of 0 to 19 years. Very common cancer in young people. And if the brain tumor is a cancerous one, majority of the patients will die within a year. It's having a very bad prognosis. Majority of the patients will be dying within a year. And less than 3%, these are all statistics, less than 3% survive for more than 3 years. So in this case, why I'm telling you these things, because in this, if you have these informations, then you can be very, you have to be very cautious while treating a case of brain tumor. You don't panic. I'm telling you every time, don't panic. We are having a lot of medicines. We are having very good medicines to combat these things, but we have to be very confident in our approach. Now, management by the modern medical system, they are having medical therapy, just symptomatic treatment. They are mostly relying on surgery. They're relying on the scalpel. They will cut the brain tumor and they will just take the credit, oh, I have cured you. And after that, they give radiation therapy, chemotherapy. And nowadays, after this radiation therapy and chemotherapy is failing, they are now insisting on immunotherapy. So different types of therapies they're having, in spite of having all sorts of this sort of, different frontiers, they are failing. And many of the cases are coming to us for help. So surgical, something that I will do a surgery and I will remove the brain tumor and everything will be okay. That's not so easy, because surgical removal is impossible in many cases. Very recently, I saw a case of a tumor in a child of 14 years. And he went to Nimhans. The doctors over there, Nimhans and the Tata Medical Center, they told that we cannot operate on this patient because it's located in a very critical condition. So it is a very common thing in brain tumor. Due to the critical position, they will not operate. Number one. Number two, even if the resection is done, that resection remains very partial one. They cannot uproot the root cause. They leave a stalk behind, and that stalk actually recurs in the future. And response to radiotherapy and chemotherapy in many cases is having some side effects. So these sort of cases are coming to us. So with this backdrop and of an idea regarding brain tumors, we'll now see how do we manage with homeopathy. I can assure you from my experience, and I'm quite sure there are many people over here who have got a lot of experience just like me with brain tumors, that we are having many medicines, we are having very micro doses of medicines which act nicely than the scalpel, because that involves a lot of risk, that involves a lot of life risk, a tension among the relatives. But with our homeopathic medicines that Dr. Hahnemann has presented to the mankind, we can do a lot of wonders. Now, our objective in managing these cases with homeopathy will be like this: to cure if it is possible. If it is a benign tumor, if it is not having a lot of pressure effect, if it is not creating any intracranial pressure, increase of pressure, not having any serious symptoms, then disturbing symptoms, then we can think or we can try to cure that tumor. And number two, after surgical cases, the post-surgical cases or post-radiation cases, when they come to us with symptoms of recurrence, with symptoms of complications. In these cases also, these post-operative cases, post-radiation cases, post-chemotherapeutic cases, we can install our homeopathic medicines and we can give a lot of benefit to these patients. So in these areas, we can try to cure. Secondly, our objective is to save and prolong the life of the patient. Wherever, I just told you that just 2 weeks back, I saw a case of a serious tumor in a case of 14 years old boy. And that case was, told by the Tata Medical Center and Nimhans that we cannot do anything. You just take him back. And this type of cases, they die within 1 year. So in this sort of cases, our objective should be to save the life or at least to prolong the life. And this also we can perform with our homeopathic medicines. And finally, our objective should be to improve the quality of the life of the patient. After the patient has suffered from brain tumor and after he has undergone radiation, chemotherapy, surgery, their life is disturbed. They cannot run the same life that they had previously. So that is our also responsibility to bring back the normalcy in their life. So we can do everything with our homeopathic medicines. Now, why are these tumor cases difficult? Why they are very difficult? Because in our clinical practice, these cases, they do not come in the first hand. This is our common experience that when the patient starts having seizures, when the patient starts having headache, when the patient starts having vomiting, they will first go to the neurologist. They will go first to the general medical practitioner, then they will go to the neurologist. They will take a lot of medicines, and after wasting a lot of time, they come to us. So that's a big challenge that we are facing. They come late when the symptoms have already progressed much. And sometimes it happens that the symptoms have progressed to such an extent that they are on the verge of death. These sort of patients are coming to us, and we have to take, because we have taken an oath to help the suffering humanity. So these sort of cases are really difficult to treat. And these patients are continuously on allopathic drugs. They are continuously on allopathic drugs, and they are very strong drugs, especially the anti-epileptic drugs. They are very difficult to withdraw. These anti-epileptic drugs, they are very difficult to withdraw. Once you ask the patient to withdraw, they will have some withdrawal effect. So in these sort of cases, you have to keep in mind that these allopathic drugs has to be tapered off gradually. So these things make the cases more difficult for us. It's not the symptoms, but this peripheral, this circumstantial things make the cases difficult for us. And we have to manage these cases very confidently. Another difficulty is that patients often cannot tell the peculiar symptoms because they have gone to the allopathic physicians. They know that they will tell the headache, blooding of vision, and they will just go for a CT scan or an MRI, and they know that these are the information that the doctors require. They don't know that as a homeopath, we require some precise information, some finer symptoms. So that is one thing. And these patients, they mostly belong to the underprivileged section. And that is also one of the difficulties, to make them understand what we want in our clinical practice, what is required for our precise homeopathic prescription. And another thing I have experienced in my life, in my practice, that these patients are very difficult to advise. Even if you advise that go for an MRI, go for a CT scan so that I can check whether the tumor is regressing, they don't follow this advice so often due to reasons, monetary reasons or other reasons. And the fourth point is that I have seen, once they start feeling better, they will leave the treatment and they will not inform you even that I am better. They will not seek your opinion. They will just simply leave you and they will lead their own life. These are some of the difficulties that we are seeing. Remember one thing, all tumors are not life-threatening. All brain tumors are not cancerous. If you remember this thing, then you will not panic. And think about the case individually. Each and every case is a challenge. Each and every case is individual, and we have to think about each and every case individually. We cannot go by the protocol. There are certain protocols over here, and I have seen in my practice applying these protocols. In most of the time, these protocols fail actually. And one of my advice from my experience is that don't panic, especially for the youngsters over here who are practicing, who are beginning to practice. Don't panic with the brain tumor cases. These are nothing that these are cases that we cannot manage with homeopathy. We can manage with homeopathy. But first decide whether the case is critical or non-critical. That is very important. Whether you are having a critical patient or non-critical patient. In critical patients, time is very short. Time is very short and you have to deliver result very soon. Say, for example, in a brain tumor patient comes to you with severe vomiting, bouts of vomiting. In that case, it's a crisis period that you are facing. In that time, you cannot go for a constitutional treatment. According to my experience, I have seen that you have to immediately counter that crisis, you have to stop the vomiting, you have to stop the seizure, you have to stop the headache. And then after making the patient stable, you can go for the detailed case taking for constitutional treatment. So this thing you have to decide on the ground, whether it's critical or it's a non-critical stage. And treatment will be according to that. In acute exacerbation, I just told you, only acute symptoms are to be targeted initially. A patient presents to you with vomiting. I have seen in my patient, in my practice, with a lot of vomiting. So you have to immediately stop the vomiting. You cannot go for the constitutional treatment at that time. These are very important. These decisions are very, very important in tackling brain tumor cases. In non-critical cases, where there is no life-threatening situation, you can take details of the present complaints with history of onset. Please try to take the history of onset. How did it start? Ask the patient. Ask the patient's party. How did it start? Very important. Causation. Take details of the associated complaints. Other than the symptoms of the brain tumor, take the other symptoms, take the modalities, take the concomitants, and try to take the mental generals and the physical generals. Very important to build up a case. And past medical and past family history is very important. Past medical history of the patient is very important. I will tell you when I go for the third case today. Constitutional treatment should be initiated in non-critical and non-life-threatening cases after the critical period of the crisis is over and in post-surgical cases in order to prevent recurrence. So we have got a lot of big scope. We have got a big scope where we can deliver with our homeopathic medicines. This was a brief explanation about the management with homeopathic medicines, how we can manage these cases. And now I will come to the third portion of my lecture, that is a case illustrations. I'm left with only 15 minutes, I think. So this case one, the first case, this is a management of an acute attack of stupor in a brain tumor case. This case has taught me a lot of things. This case came to me when she was only, I think, 16 years old. When she was only 16 years old, and now she is around nearly 40 years, and she is still surviving. And she was diagnosed to be suffering from cystic tumor located in the posterior fossa near the brainstem. And she was operated for 2 times, in 2001 and 2002. They went to Bangalore and they got the cyst operated because she had a tremendous headache, she had vomiting, even she lost consciousness. And in 2002, again that tumor recurred. And they again went to Nimhans and they told that if we go for a third resection, if we go for a third operation, it can become fatal. The patient might not survive. And after hearing this, they came back. The patient was brought back and they came to me in 2002. They just requested me, doctor, you just stop the recurrence of the tumor so that the tumor is not progressing. Even if the tumor is not going on, just do something with your medicine so that the tumor does not recur, so that we don't have to go for a life-threatening operation. Presenting complaints was, I'm just telling you some of the presenting complaints of this case, but I will go to the acute phase of this case. I will just illustrate that one. Presenting symptom was headache, a continuous headache with nausea and vomiting. Especially the nausea and vomiting was from smell of food, especially smell of fish. She cannot tolerate the smell of fish. She had got anorexia. There was a lack of proper balance. When she was walking, her gait was not proper, and she was actually going away from the straight line that we normally walk. She was very irritable, aversion to suggestion and advice. And one thing I got, that she was averse to mix with the girlfriends, and she liked to play with the boys. She was just a boyish girl. She liked to play with the boys. Now, I remember the first prescription that I made for this patient, because this patient came to me with severe headache at that time in 2002. I prescribed Natramune. and I went up from 630 to 100 to 1M also I went up. And after that, I required Netron Sulf. In cases of vomiting, when there was some exacerbation of vomiting, I had to give arsenic album. I remember she had 1 or 2 bouts of severe vomiting, which was aborted by the prescription of arsenic album. Then sometimes, while the treatment was going on, she had some bouts of vertigo, dizziness, and I had to take recourse to Coniamac. It's a very good medicine for us. And finally, I had to give Plumbermate in some situation also. Plumbermate is a very good medicine for brain tumor that we are having. So these are some of the medicines I remember I gave to this girl. After the treatment with homeopathic medicines, now she is leading a normal life with a few acute paroxysms. I can tell you one thing. Initially, when I started the treatment in 2002, after starting the treatment, there were several bouts of acute phases like acute vomiting, acute difficulty in walking, acute cases, episodes of unconsciousness. And now these things have totally passed off. She never vomits. She has not a single episode of unconsciousness. Now she's having some sort of headache sometimes. And latest MRI suggests that the partially resected tumor has developed calcification and is in a residual non-enhancing stage. This is also an achievement with the homeopathic medicine, that a tumor has been stopped over there, calcification has been done, and when calcification has been done, you can be sure that this tumor has got very little chance of recurrence. Now, I will present to you the acute stage, the acute stuporous condition that came to me. I told you one thing, that this case taught me a lot of things. And this is one of the episodes. And I can tell you one thing, that while seeing this sort of cases, it is very difficult to take videos. Very difficult to take videos in these brain tumor cases, because they are very sensitive cases, sentimental cases. And just in this episode of acute stupor, I requested the parents that, can I take the video of this patient? And they gave me the permission that I can take, and that is the reason I can show you. So at that time, she was around 30 years, unmarried, became stuporous. It was in the year 2013 and 14. And she suddenly became stuporous one day and was dragged in my clinic. She was virtually dragged in my clinic. She was responding to the calls vaguely, and there was an absolute drowsiness. She was very drowsy, not sleeping. She was not in a stertorous sleep, but she was drowsy. Gait was unsteady. You can see the video. When you see the video, you can just note that thing. She was complaining of dual vision. She cannot see properly. Diplopia was there. She was having headache. She used to pull the hairs when she was having severe headache. Now, how did this start? When I asked the mother, how did this start? She told me that she had a quarrel with her. The daughter quarreled with her mother because she wanted to go for a picnic with her friends, and the mother denied the permission. So that was a result of her excitement, a disappointment, and excitement out of quarrel. And following that, she had got this acute attack. Now, this first day, you can see this was in 24th of December 2013. I am showing you the video. Just see how the patient, she has entered my clinic. She's sitting in the chair in a listless position. You can see her head is drooping back. She has got no control over the head. So this was one of the acute attacks. Earlier also, I have seen this patient having this sort of attacks. Even one day, I remember she was brought to my clinic when she was totally unconscious. She was brought by 3 persons into my clinic. And that day, Carbovage helped me very much to revive the consciousness in this patient. Now, this was December. It was a cold morning. She had this attack of stupor. The audio is not working actually. Anyway, the mother is holding her hand. You can see that she has got no control over herself. Just
Dr. Partha, you have to hurry up your case because
Okay, okay,
The
okay,
time
okay,
is
okay.
coming up.
Okay,
But
okay, okay,
if
sure.
we can ask the Malayalam session to give us some time, because I think
Okay,
there'll
no
be
problem.
some question and answer
Just
later
see,
on.
just see
Uh,
how the patient is lying. How the patient, when I was examining how the patient was lying, she was just lying like a log. This was on 24th of December. I will change the slide. Rubrics I took. These are the rubrics I have taken. Mind symptoms, mind stupor, answers confused answers, and answering very slowly. And generalities I have taken reeling gait. This was the repertorization. And after repertorization, I can see that Heliborus was coming. And I prescribed Heliborus 30 on 24th of December. Then the next day, the patient was brought to me. She's still in this condition. See, she cannot see properly because of double vision. Slightly better. Still, she's having some headache. I just move the video fast. She's still in the semi-stuporous condition, but what I saw is that she was slightly better than the 20 as she was 24 hours before. Because these cases are very critical cases because all the relatives are after her parents that why are not admitting her to the hospital. Next day, 25th, she arrives much better, still having blooding of vision, but she's responding to the normal pulse. And just after 24 hours, see, follow up, no need to hospitalize the patient. And I prescribe Ignatia 1M. 26th of December, she arrives much better, walking almost alone without help, and she's laughing. This is a video I'll show you. She's entering my clinic. This is a smile that we want in every patient. This is a smile that we expect in every patient. Now she can sit steadily. Within just 48 hours, within 48 hours, she is sitting steadily with our homeopathic medicines and single medicine. No recur of scalpel, no recur of big allopathic medicines. The mother is also relieved. So I'll move fast to the next slide. The second case is that of astrocytoma. I told you that these are malignant cases, astrocytoma. A 54-year-old male was brought with symptoms like sudden attack of slurring of speech, distortion of face with inability to recognize persons 2 weeks before. The patient party told us that he was slightly having some difficulty in recognizing patients, but suddenly one day he had a slurring of speech and distortion of the face. The face was distorted and was hospitalized, and then CT scan was done, and it was diagnosed as a case of astrocytoma. This is the CT scan. It was done in a government hospital over there. You can see that in February 2016, the CT scan was done where it was written low-grade astrocytoma. So they are nearly cancerous cases. They are nearly malignant cases. Then just to get this confirmed, they went to a super specialty hospital over here. They did a MRI, and the MRI also told that yes, it's a case of astrocytoma, and they have localized it in the frontoparietal region, February 2016. And there was perifocal edema. You can note perifocal edema. That means that is causing some pressure effect in the head. Presenting symptoms were lack of proper balance, slurring speech, difficult or misrecognition of persons, incoordination, nausea, forgetfulness, confusion, headache, mostly in the frontal region, and sometimes pain in the chest. Pain in the chest was not related to the brain tumor. this patient had got some hypertensive problems. He had a cardiac problem with hypertension, and that is the result of that is the cause of the chest pain. He was a car driver. He had a business, and there was no history of head injury, no emotional or mental trauma. Rubrics that I took were confusion of mind, does not recognize anyone, forgetful. These are mind symptoms. Then localized the particular symptoms that I took: tumors in the brain, speech difficult, and tottering gait in the extremities chapter. And plumbar metallicum came after repatriation. Plumbar metallicum. And plumbar metallicum, if you go through Bodix Metrimetic, you will find that it's a very good medicine for the symptoms that we find in cases of brain tumors, especially malignant brain tumors. Plumbar metallicum 6 weekly doses was given to the patient with calcarea fluor 3x, and it was continued for 3 months. Intercurrent medicines were used for headache. Belladonna was used for vomiting or nausea. Ipecac was used. Sometimes cupramet was used. And after plumbar met, he was put on different constitutional medicines like beratacab, natramute, etc. He was treated for 1 year. After 3 months of treatment, the tumor is showing improvement. This is the CT scan after 3 months. The earlier one was in February. This is in May. You can find that there is still a mass in the brain, but the radiologist is writing that there is a response to the treatment. She is writing that follow-up treatment. The patient has now hypodensity and decreased mass effect suggestive of response to treatment. That means the homeopathic medicines are responding. The mass is going down. And in 2017 February, they went for a repeat scan, CT scan. Now you can see the radiologist is writing over here. An impression is there. An impression is there. After the storm, there is some impression. But you find no residual tumor is noted. No residual tumor. The astrocytoma is totally gone. Without the intervention of a scalpel, without the intervention of radiation therapy, this tumor has gone. Patient did not follow up further, but still he is fine because many of the family members are coming to me. And the third case, so this is a case of solitary granuloma. Granuloma means an SOL which is formed in the brain. It's due to some inflammation or infection due to some foreign objects. It is a benign tumor. It's a benign SOL that happens in the brain. It's not malignant. This case presented with headache, associated nausea, vomiting, on eating. This case came to me in 2015 with blurred vision, photophobia, vertigo. The patient was in acute distress. When he came to me, patient was in acute distress. What was the distress? The distress was that he was having a throbbing pain. It was very severe. And the pain was sensitive to external impressions like light, noise, and more so, he cannot tolerate anything. And that this external impression like light and noise was causing some sort of nausea. So intolerance, absolute intolerance to light and noise was very important in this case. He was in such a distress that he wanted to commit suicide. He told me that give me some medicine so that I can die. I cannot tolerate this headache. It was unbearable. The pain was unbearable to him. He went to specialist doctors. He even went to some homeopathic doctors. Okay. Modalities, aggravation, lying down, any noise, any light, pneumonia. And over here, you see there's an interesting past history. I told you that past medical history is very important. Over here, he had got a history of worms. He had got a history of worms and dry eczema. Now, the CT scan of September 2015 tells that there is a solitary granuloma, only one granuloma, solitary granuloma in the brain with edema in the supratentorial ventricles causing a pressure effect. That is the result. That is the reason for the severe headache that he was having. And you see in the blood report, there is an increased eosinophil. Very interesting. He's having a history of worms and the eosinophil count is high. This is an indirect indication that he was suffering from a worm infection. I prescribed Theridion for this case because he came in an acute situation. The headache was severe. Though Theridion did not come in the repatriation, but still I gave Theridion because of the nervous hyperesthesia. And Bodix writes that Theridion is, can be given when the indicated remedy does not hold long. MRI brain 2015, November 2015, granulomatous lesion, possibly neurocysticercosis. This is a granuloma that results out of Tinea solium infection, parasitic infection. Okay. You can see the brain MRI over here. I'm just moving the cursor over here. Granulomatous lesion in the right side of the tectum, possibly neurocysticercosis. The bottom line is that he is suffering from an intracranial SOL by the name of granuloma, and he's having a lot of problems. And that is the thing which we have to cure. I gave Theridion just to reduce the headache so that the patient gets some relief. And after that, he was having some residual headache. For that, Spigile was given. As Spigile has got an infection for eye, heart, and nervous system, neuralgia. And Spigile is a very good medicine for worms also. It's a very good medicine for worms. So in all the aspects, Spigile was indicated. And 10 February 2016, the patient reported that he is much better. But interestingly, old symptoms have started recurring. Old symptoms have started coming back. The headache has come down. Now the old symptoms like eczema in the hands, gastric problems like bloating, they are coming back. Now, when the old symptoms are coming up, it's an indication that we have to change the remedy. And after repatriation, these drugs came, lycopodium, pulsatile sulfur, and natramute. And I prescribed lycopodium 200. And there was further follow-ups in March, April, May. And finally, he went for another MRI in June 2016, which showed, you can see over here, normal study of the brain. The granuloma has gone. Interestingly, this granuloma, some may ask a question. In fact, one of my friends asked me a question. Did that patient took any antiparasitic medicine in between? I told no. He was very sincere to me. He was very sincere to me. Without taking any antiparasitic medicine, that granuloma was totally gone. So this was my brief presentation regarding brain tumors. I hope I have been able to deliver some of my experience to you. So thank you very much for providing me this opportunity.